Good afternoon. I'm Mohamed Abdallah, a year 2 resident. I'd like to represent the case of bilateral ovarian neoplasm under supervision of Dr. Asma Magdi and Dr. Amal Ibrahim. Clinical history: a 62-year-old female patient referred to our MRI unit for dynamic pelvic abdominal MRI. The patient's main complaint: deep pelvic pain and weight loss. The patient had an ultrasound reported the uterus is overlapped by a heterogeneous mass of mixed heterogeneity, probably of ovarian origin. The patient has a positive history of hepatitis C virus. Surgical history was free. ده كان فيديو بس الاكزيال تي 2 بس مش مشكله انا واخد صور. احنا شايفين هنا في الصور في bilateral adnexal heterogeneous soft tissue mass. Right show mixed cystic and solid, left predominantly solid with cystic area. الsolid component showing low في 2T low signal في T2 وبرضه low في T1 with heterogeneous post-contrast enhancement with true diffusion restriction. pelvis برضو الباثولوجي اللي شايفينها فيها ان في ascites, omental implants and lymph nodes. omental cakes. ده كان فيديو برضو للبلفس الابدومين بس مش شغال. We continue to see the ascites, peritoneal and omental implants, pathological looking lymph nodes. To summarize, we have a bilateral adnexal heterogeneous soft tissue lesion with heterogeneous post-contrast enhancement and true diffusion restriction. Massive ascites, peritoneal deposits, mental cakes, multiple enlarged suspicious abdominal and pelvic lymph nodes. Differential diagnosis of bilateral ovarian lesions. First, primary ovarian cancer, which is predominantly cystic. Secondary or metastatic, they're usually solid but can be also mixed solid and cystic. And lastly, ovarian lymphoma, which is usually homogeneous and solid masses. It's not our case. So our differential diagnosis is primary versus secondary metastatic. Krukenberg tumor is a subtype of secondary metastatic tumor. The most common to send the metastasis is stomach followed by the colon. Also breast, lung, and the contralateral ovarian can be primary tumors. The tumor represents 50% of all metastatic tumors. They are usually solid, as we said, but can also show areas of cystic and can be difficult to differentiate from primary ovarian tumor. Our radiological report by Dr. Amal Ibrahim, bilateral adnexal mostly ovarian heterogeneous masses showing MRI malignant features associated with massive ascites, peritoneal deposits, mental cakes, and suspicious looking lymph nodes. Possibility of primary versus Krukenberg tumor for GIT endoscopy and tumor markers and PET CT. We followed up the patient. Tumor markers were negative except for CA 125. Upper and lower GI endoscopy were free. And lastly, the pathology report from mental cake through cut biopsy. It was a metastatic adenocarcinoma of ovarian origin. These are my references. Thank you.
Thank you, Dr. Mohamed, for your